Good afternoon. This is a short video that would help you prepare your video for the clinical case study that is required from you for semester one project. As you might have read in the handout, you're gonna discuss a clinical condition that describes a patient or the condition of a patient who has a muscular disease. But since tendons and ligaments are very closely related to muscles, therefore you might discuss a muscle disease or a tendon disease or a ligament disease. So you might discuss a disease that is related to the muscles or that is related to the tendons or that is related to the ligaments. And we have a diversity of muscular diseases that we can discuss. Needless to say that accurate history taking is a very important clue to diagnosis. And by the end of a good history, you should have made a very close idea about the differential diagnosis or the possibilities of diseases that might cause the presenting clinical condition. And upon examination, you taper or narrow this list of possible differential diagnosis or possible diseases that might have the same clinical presentation, so that after having finished your history taking and your examination, you can ask for a few investigations. And the role of the investigations here is to help you taper more and more the list of differential diagnosis and reach an almost correct single diagnosis for all the symptoms that you have heard and for all the signs that you have found upon examination. Needless to say that there should be a systemic approach, meaning that there should be an organized set of steps that should be followed more or less strictly, because if you miss any of these systematic steps or organized or sequential steps, you might miss an important detail, whether in the history or in the diagnosis or in the examination or even in the investigations, because even during the choice of investigations, we should start by the commonest and leave the less common and more expensive investigations to the end. Moreover, the investigations should be relevant, meaning that it's not acceptable to ask plenty of investigations, from the patient, not only because this would cost him a lot, but because this would consume a lot of material and would indicate that you don't know the diagnosis and that you're just trying to do as many investigations as you can, or maybe one of these investigations might lead you to the clue or to the diagnosis. So a systematic approach is very important. And by systematic approach, we mean an organized approach that follows the conventional steps of the history and examination that all previous medical doctors have agreed upon. Of course, in such a case, in this project, you're going to imagine that you are a medical student and that you're going to present a case to your colleagues in the School of Medicine or to your professors. Or on the other hand, you might imagine that you are a teacher in the School of Medicine or that you are a professor and that you are presenting a case, an interesting case that came to your clinic or that came to the hospital. So you can go either way. Another important thing is that you can also choose between saying at the beginning what condition you're gonna discuss, or leave the diagnosis to the end for a discussion between you and your students or your colleagues. The ultimate product of the project will be a video, and in that video, you will be wearing or putting on a white coat. And in this video, pictures are required because you might give pictures of the lesion itself. For example, if you have a muscle bruise or a muscle laceration or an anterior horn of the medial meniscus that's torn, or the anterior or posterior cruciate ligament. So you might you might include pictures, and you might also include very short videos if it is needed, or very short animations. You can select whatever disease you want, and or whatever type of injury. It might be a disease, or it might just be a traumatic injury, and you're gonna present it. Time is not specified because it depends on the condition. And of course, before making the video, you should prepare a sheet, the medical sheet of the patient, which will include, first of all, the history of the patient, the results of examination, the results of investigations, and then the treatment guidelines. And by treatment guidelines, I mean that you're gonna tell me what lines of treatment you're gonna follow, but you are not gonna mention specific trade names or commercial names of any medication. The medical sheet will be written for you. I'll not look at it, I'll not correct it, but you do it for yourself so that you can just have it in front of you on the desk while you are recording the video, or you can just rehearse from it, but it's not a requirement, and I'll not correct it. I'll just evaluate your video, and the evaluation of the video will be as the rubric says here, as you see on the screen. But before seeing the rubric, it's needless to say that if you have results, lab results for the patient, like results of a blood picture or results of urine analysis, or if you have an X-ray for a bone injury or a joint injury, or an MRI or a CT scan, or even the results of a sample or a biopsy from the muscle that shows the pathology and the changes in the tissues, you have to show this. The more the pictures on the video, the more it's interesting. The rubric is divided as follows. The content, the medical content, is worth 40%. How systematic you are, how systematically you proceed, is worth 20%. Your presentation skills, you will try, of course, to make the case attractive to the audience, and to make them engaged in watching the video till the end. You will try to be non-monotonous, meaning that you will change the tone of your voice. You will talk as naturally as possible, as enthusiastically as possible. You will use very discreet terms. You will be self-confident. You will be looking at the audience. You will be changing the tone of your voice. All these are presentation skills. And you should show on the video, of course, meaning that it's not acceptable that you display, for example, a PowerPoint presentation. No, a PowerPoint presentation, a video of a PowerPoint presentation will not be acceptable. The quality of the video, including the presence of diagrams and pictures and some labels, on the screen, all this is worth 15%, and abiding by the deadlines that you see on the screen is worth 10%. In the medical sheet you're going to prepare before the video, you're going to start by the medical history. And the medical history is divided into several categories. And the first one is the personal history. And the personal history includes all the important and relevant personal information about the patient. And it's worth mentioning that if the personal history is displayed here on the slides in the form of titles and subtitles, yet whenever you read the medical sheet in front of the audience, your classmates or your students, or in the video, you're going to present it in the form of a paragraph. The personal history should include, of course, the name first of the patient, which is not written here, because it goes without saying that you have to know the name in order for you as a medical doctor to know which patient you are talking about, and in order for all the following medical doctors that will be in charge of the condition, that in order for them to know which person they are dealing with. And then you have to include the age, since certain, is the age important? Yes, because when you hear about the age of the patient, you can determine what categories of muscle diseases can be excluded and what categories can be included. For example, if the patient is very young, for example, 2 years or 3 years of age, then it might be something congenital, a congenital myopathy. A myopathy is a muscle condition that is characterized by muscle weakness because of a disease in the muscle itself. It's not a neuromuscular disease. And myopathies might be congenital. Congenital meaning that the child or the newborn is born with the disease. But congenital diseases in general might be genetic or non-genetic. They might be due to a gene disturbance or not. So the term congenital is broader and more inclusive than the term genetic, because not all congenital myopathies will be, or not all congenital diseases in general will be genetic diseases. Mentioning the gender or knowing the gender of the patient is also important, because there are certain diseases like muscular dystrophies that we will be studying in the classroom are more common in men than, or in males than in females. Sometimes the race is relevant because Hispanic individuals, for example, or people of Hispanic origin have a greater incidence of a kind of muscular disease that is called Duchenne dystrophy. The current residence is also important because certain areas in Egypt, like in South Egypt, have a higher incidence or a higher prevalence of neuromuscular diseases. This might be due to genetic disorders, because maybe these communities are closed communities where the individuals inside the community intermarry and interbreed, resulting in in a higher prevalence of a certain genetic disorder within this narrow genetic pool, or because of an environmental effect or a cultural effect. And then the career is also important because, for example, a very simple and famous example is when the patient is a football player or a sport player in general, then this patient would be more liable to traumatic diseases than other people. Of course, as I said before, you will present the personal history in the form of a paragraph. So you will never say present history, number 1, name, number 2, age, number 3, gender. No, you would say it in a smooth paragraph, meaning that last week, for example, last week, a 40-year-old female called so and so and so came to the clinic. She is of Caucasian origin. She is married. She has 2 children. She lives in Cairo. She works as a teacher, and so on. So you would be covering the 5 or 6 items of personal history, but in the form of a paragraph. And this will apply to all the rest of the histories. For example, the present history. If the personal history was like a summary or a resume of the personal information of the patient, then the present history is the analysis of the present complaint, meaning that the patient comes to the clinic complaining of something, and this should be highlighted. It's not in the titles, but the present history is mainly about the complaint. What urged the patient to come to the clinic? This is the present complaint. And as we have said several times, the present complaint should be said in or described in the patient's own words, even if these words are not scientific. And this is the only part of the medical sheet that will be written in the patient's own words. For example, the patient might come complaining of pain in the knee joint. So you would say that the patient came to the clinic complaining of pain in the knee joint. And then you start analyzing that pain. You start asking the patient questions around that symptom, which is the pain, in order to analyze this complaint in a trial to know the underlying cause, what the possible underlying cause or causes might be. But so it's important to know that the present history will be information around the present complaint, but you will never gain this information in the present history without asking the patient questions, because you will never examine the patient at this stage. So you will start to ask questions, but you should avoid leading questions that might force the patient to answer a particular answer. For example, don't ask the patient, is this a pain or has this pain resulted from a traumatic injury? But just ask him what triggered the pain, what brought the pain, what caused the pain. So don't ask leading questions that contain the answer, because the patient, the doctor is very influential on the patient. So the patient might feel that he should be answering from the content of your question. So you will ask about, first of all, the site of that pain. The site is not written here, but the site is important. So first of all, we would, before asking about the onset of the pain, we would say, number one, the site of the pain. Where is the pain exactly? Is the pain in the knee joint? Is the pain in the muscle above the knee joint, etc.? So number one, the site. The site is important because it gives you a rough indication about the organ that might be affected. So it gives a rough indication about the structure that is affected, the structure that is affected. Okay, so the site is important. Second, and before, or let's leave it after the onset is important, because if you have a gradual onset, if you have a gradual onset, then this is a chronic condition. But if you have an acute onset, this might be traumatic. So if the patient tells you that all this trouble has occurred all of a sudden, then it is an acute onset, and most probably it might be due to a traumatic injury, another football player kicked his knee joint, or the person fell on the ground and injured his knee joint, or there was a trauma to the muscle, and so on. So the site is important, especially if we're talking about pain. The onset is important. A sudden onset or an acute onset might be due to a mechanical trauma or an infection, and a gradual onset might be due to a chronic disease. Of course, that you might be wondering, how would I proceed throughout the sheet if I don't know the case? You will imagine that you have examined, for example, a case of poliomyelitis or a case of traumatic injury to the anterior cruciate ligament, and you will tailor the present history and the results of examination to fit within the choice you have selected. But throughout the medical sheet, history and examination, you have to be consistent. You have to keep in mind the diagnosis that you already have in mind. For example, I have decided to talk about a condition of poliomyelitis, or I have decided to talk about a condition of hemiplegia. So all the data that I give in the present history and in the rest of the examination should be matching with the choice that I have made at the beginning in my mind. The duration is consistent with the onset, because when you have a chronic gradual onset, the duration is usually long. But when there is an acute sudden onset, the duration is usually short. And then before what triggered the symptoms, the quality of the symptom, especially in case of pain. So, for example, if the pain is dull aching pain, this might be a muscle pain. If the pain is sharp pain, this might be a traumatic injury pain. So the quality of the pain, meaning that with the site, we should also have added distribution. So when we say the site, it is the site where you have the maximum display of the symptoms, maximum display of the symptoms. For example, the pain is maximum on the quadriceps muscle. This is the site of maximum display of the symptoms, but you can also add to this the distribution, meaning that there might be weaker pain in other areas. You can also add referral of pain, because the main pain might be in the back, for example, but it can also be referred through nerves to another area, for example, the back of the leg in case of sciatica or inflammation of the sciatic nerve. Okay. And then we have after the duration, we have the quality. Concerning pain, quality is very important. So is it sharp pain, or is it dull, diffusing pain, or is it a colicky pain? Of course, colicky pains are not related to skeletal muscles, but they might be related to smooth muscles or the muscles of the internal organs. And then what triggers the symptoms? This is very important, because if the symptoms are triggered by emotional stress, then this might be an autoimmune disease. If they are triggered by mechanical stress or physical stress or trauma, this might be something traumatic. Are they side effects of medication? For example, the patient says that I was okay until I took high doses of cortisone for a whole year. Then I started discovering that I have weakness in the muscles of the lower limb. Similarly, what relieves the symptoms? Are the symptoms released by rest? Are the symptoms released by analgesics? And this is important because if the symptoms are not relieved by rest nor by analgesics, this might give you an indication of the severity of the disease. And then we have the associated symptoms. The associated symptoms are sometimes very important in or might be a clue to the diagnosis, and the associated symptoms might be, for example, swelling, they might be redness over the area of pain, they might be a red rash, they might be atrophy. All these are associated symptoms, but related to the same system, meaning that they are related to the muscular system. This is different from the systemic symptoms. The systemic symptoms are still associated symptoms, but in other systems other than the muscular system. For example, if your muscular disease is due to an autoimmune disease, you will have low-grade fever, you will have generalized malaise and easy fatigability, you would have loss of appetite and weight loss. So there is a difference between what we call the associated symptoms. Here we mean associated to the main complaint, which is essentially here muscular or tendinous or related to the ligaments. But there are other associated symptoms that are related to the rest of the body systems, which we call systemic or generalized symptoms. And then it's also important to ask about response to treatment, if any, because the patient might not have taken any other treatment before, he might not have visited a doctor, but you can ask the patient if he has sought medical advice, what kind of medication he took, and if there was any response, positive or negative. Of course, again, the present history should be written in the form of a paragraph. After having finished the present history, you move on to the past history. And the past history is essentially that you're asking about previous similar episodes. For example, if the patient comes complaining of a giving way that made him fell in the middle of the street, you have to ask him if this is the first time he suffers from giving way or not. Of course, you will not force the patient to talk about a particular symptom, meaning that if the patient has never suffered from giving way, don't ask him, for example, is there any giving way, unless you feel that the condition is mainly related, is most probably, for example, an injury to the anterior cruciate ligament, and that there might be a strong possibility of giving way. So sometimes we ask in the present history, and even before reaching the past history, after having finished this systematic approach of the present history, you might feel that you need to ask more questions to the patient before moving on to the past history. This is important because the patient might have missed a certain detail, and by asking more questions that you feel important and relevant to the condition, then you're helping yourself and the patient to reach a diagnosis. In the medical history might include any other medical diseases that the patient might have suffered from, or drug history. So sometimes we merge the drug history with the medical history. Sometimes the medical history is important because the patient might tell you that he is suffering from chronic renal failure, or that he is receiving hemodialysis for a renal failure, because chronic renal failure might result in a kind of muscle weakness that's not, of course, congenital, but that is acquired. Sometimes the condition is iatrogenic, meaning that it is resulting from the treatment itself. For example, the patient took steroid therapy as an anti-inflammatory medication for his autoimmune disease, and then as a side effect of the medication itself, the patient was relieved from the pain, but as a side effect of the medication, he suffered from a weakness of the muscles. The family history is important, as we said before, because it might be a congenital disease, genetic or non-genetic, or there might be a cultural correlation, meaning that those people live in the same environment, eat the same type of food, has the same way of living, and therefore they are liable to have the same diseases. So family history might indicate a genetic predisposition, or it might just be due to sharing the same environment. So you have to ask whether other members of the family have the same condition. The patient's job or the occupational history is important, as we said before, because sport players are exposed to repeated injuries. People living in poor rural areas or even urban areas that contain factories might be exposed to pollutants. Travel history is also important because travel history might be the clue to a certain rare infection, for example. And as we said before, the drug history might be put under the medical history. Smoking and alcohol, you have to ask the patient if he is a smoker or not. And if he is a smoker, you have to ask him how many cigarettes per day he consumes or he smokes, because if he is a heavy smoker, this heavy smoking might result in severe vasoconstriction of the arterioles of the limbs and might result in symptoms like intermittent claudication or intermittent limping due to severe pain after having walked for a few steps and so on. Alcohol and smoking, especially smoking, reduces the absorption of calcium from the small intestine and obviously will affect the strength of muscle contraction and the strength of the bones. And then we move on to the examination. Similarly, when after having finished the examination or after having imagined that you finished the examination, you're going to mention it in the form of a continuous smooth paragraph. In all medical cases, we start by the general examination and then we move on to the local examination, which is the examination of the system in question. And here for this project, the system in question is the muscular system. In the general examination, in general, we start by observation and then palpation and then percussion, which we'll be discussing in the classroom because it has to be visualized. And then finally, we have auscultation. Percussion and auscultation in the muscular system are not that important. They are done, but they are not of crucial importance. But what is important is the observation and the palpation. And by palpation, we don't only mean that you're going to palpate the muscle, but you're going to hold the limbs and flex them, extend them to feel the tone. And that's why you have to be aware of the normal tone, because if you don't know the normal tone of a normal muscle, you would never realize upon flexing and extending or rotating a joint that the muscles around the joint or those limb muscles are hypertonic, having an exaggerated tone, or hypotonic and flaccid. So if you don't know the normal, you would never be able to detect the abnormal. Let's go back to the general examination. And as we have said, the general examination is done in all cases. So in any medical condition that you will be discussing, during examination or at the beginning of examination, you have to start by the general examination. And first of all, you have to assess the vital signs. Why do we call them the vital signs? Because they are essential for life. So you have to measure the pulse of the patient, the body temperature. Of course, you measure the pulse from the radial pulse, and we will be learning this in the cardiovascular system. But here, I'll never ask you in the video to show me how you measured the pulse, but I need the results of the pulse as a guideline to telling me whether the patient has a certain disease or not. So you would say, for example, that the results of general examination revealed that the pulse of the patient was 80 beats per minute. Of course, in the pulse, we mentioned the rate and the rhythm. So it's not enough to say 80 beats per minute or 70 beats per minute, but you should also say you should also give a comment about the rhythm, meaning that is it regular or irregular. And then the temperature, the core body temperature was found to be 37.4, for example, and the blood pressure was found to be 130/90. Of course, you should select values for the pulse, temperature, and blood pressure that match with your condition. For example, if you're talking about a congenital myopathy and it's a young kid, a 2-year-old kid, it wouldn't be appropriate or logical to say that the blood pressure, for example, is 180/90. This is a very high value of the blood pressure, and such high hypertensive cases are usually not found in young kids. And then you move on to the observation, essentially the neck veins. And you can refer to the PowerPoint presentation in grade 10 about the examination of the neck veins. You have to say whether the neck veins are congested or not. And if in a young child you find that the neck veins are congested, this might be an indication of right ventricular enlargement, hypertrophy, or failure. And this might be due to a congenital anomaly that might be associated with another congenital anomaly in or another congenital disorder, not anomaly, sorry, related to the muscle. So you might sometimes have a correlation between the heart condition and the muscle condition. You also have to observe signs of anemia. Why am I saying signs of anemia? Because we haven't yet reached the level of the investigations. Of course, the definite final diagnosis of anemia or diminished count of the red blood corpuscle would be through a complete blood picture and estimation of the red blood count. But until we reach that stage, you can just assess the signs of anemia, which are mainly pallor and dyspnea, or rapid shallow breathing. How would I assess pallor? Is it by just looking at the skin of the patient? No, it's through the color of the mucous membrane. So you have to invert the lower lips in order to see the inner mucosa of the lower lips and see whether it's pinkish and healthy or pale. Similarly for central cyanosis, because central cyanosis is detected through the bluish discoloration of the tongue and the inner mucosal membrane of the mouth, and it might be an indication, or it is usually an indication of hypoxemia or low oxygen that might indicate an abnormality in the heart that might be associated with a congenital myopathy. Central cyanosis differs from, as you know, peripheral cyanosis, where you have bluish discoloration of the nails due to cold weather or due to a poor peripheral circulation. As we said last year in human biology, that central cyanosis might be associated with clubbing of the fingers, and you can refer to the PowerPoint presentation of the integumentary system. This wasn't last year. This will be studied this year, inshallah. And then the level of consciousness of the patient. This is part of the general observation. Of course, I wouldn't ask you to give me a detailed leveling of the level of consciousness of the patient or of the status of consciousness of the patient, but it's enough to say that the patient is fully conscious or semi-conscious or unconscious, for example. And then you start examining the rest of the systems rapidly, the chest, the heart, the abdomen, because as I said, there might be a correlation between the abnormalities you find in the muscular system and the abnormalities you find in the chest. For example, if you have a patient with paraplegia or, a patient with quadriplegia, the four limbs are paralyzed and maybe the muscles of breathing are paralyzed. This means that the patient is unable to take deep breath, and this might result in chest infection. So it is important to, or it might just be a coincidence, but it's good to know that the patient has a chest infection to treat it and to improve the prognosis or the fate of the patient. And then we leave the local examination to the end, which is the examination of the system in question. And as we said before, the same systematic steps: observation, palpation, percussion, and auscultation. We will skip or ignore for the moment percussion and auscultation. We will focus on observation and palpation because they are easier than and more required than percussion and auscultation. You can, in observation, you just observe with your eyes, you don't touch the patient. You might notice that there is diminished size of the muscle, atrophy, or increased muscle bulk, hypertrophy. And of course, the best way is to compare the two limbs, because sometimes the lesion is unilateral on one side. So comparison in such a case is good. You can also, during palpation, measure using a tape. You can measure the circumference of the muscles of the legs and see that one limb is atrophic. One limb has a lower circumference or a smaller circumference than the other. You might also observe the presence of a rash, like red spots on the skin, or the presence of diffuse redness and inflammation on the skin, or any kind of deformities or twitches and fasciculations, which are very characteristic of lower motor neuron lesion. And then after having observed the whole body, you start by palpating, and you palpate. Of course, we don't, in the local examination, we don't observe the whole body. We observe only the part of the muscular system in question. And then similarly for palpation, when you palpate with your hands, you look at the patient's expressions, facial expressions, because if the patient is in pain, this will be reflected on his face. By palpation, you can also feel that there is abnormal warmth on under your hands, which might indicate that this area is inflamed. Or during palpation is also, as I said before, by flexing and extending the joint, and during flexion and extension of the joint, you might feel stiffness of the joint. And then you test muscle strength. First, you ask the patient to move the joint actively, on purpose, or voluntarily, meaning that you will ask the patient to move the knee joint, for example, to flex the knee, or to extend the knee, or the elbow joint. Of course, if the patient is hemiplegic or if the patient has paraplegia, he wouldn't be able to move the limb on purpose. In such a case, you would start I'm sorry, I had a sudden stridor because of an acid reflux. So if the patient is capable of moving the joint actively, you will start by adding resistance, meaning that if you ask the patient to extend his leg, then you would push with your hands the leg during extension in the opposite direction in order to see whether the patient has the power to extend against resistance. Of course, if the patient extends on his own but cannot extend against resistance, this is a weaker level. But if the patient can still extend forcibly against your hand that is resisting in the opposite direction, then this is good strength of the muscle. If the patient is unable to move the joint or the muscle, whether in flexion or extension or rotation or whatever, if he is totally unable to move the muscle, then you will just assess or test the tone of the muscle. Is the muscle spastic? Then this goes with hemiplegia, for example, or upper motor neuron lesions. Or if the muscle is flaccid, then this would go with lower motor neuron lesion. After having finished the examination, you have a list of possible causes, and you're going to do certain investigations. And of course, these investigations have to be started by the least expensive and the commonest and the most relevant investigations, and you keep the more sophisticated ones to until you see the results of the preliminary investigations, because sometimes the clue to diagnosis is obtained from these simple investigations. We can ask for a plain X-ray if you are suspecting, for example, a fracture in the bone or osteoarthritis, which is a degenerative condition of the knee joint, or a tear in the medial meniscus or in the lateral meniscus. You can ask for a blood analysis if you're suspicious of an associated anemia, the level of calcium, because if the patient has muscle weakness, you have, or tetany, on the other hand, you have to assess the level of calcium. And you might also ask for certain enzymes like creatine kinase, because creatine kinase is an enzyme that is released from the muscle when the muscle is damaged. You can also ask for magnetic resonance imaging, but notice that MRIs should be avoided if the patient has had a previous surgery on a joint or on a bone and has screws and plates, because it involves a magnetic field that might attract the screws and displace them. You can also ask for a CT scan. The CT scan is very informative, but it's a huge dose of X-rays, hundreds of times the normal dose of the normal X-ray, which is already harmful, and it should completely be avoided in pregnant females because it is teratogenic. It causes congenital anomalies. If you're suspicious of an autoimmune disease or a disease that involves the tissues of the muscle itself, you can ask, or a malignancy in the muscle, you can ask for muscle biopsy, where you take a sample from the muscle and examine it under the microscope. You might ask for genetic testing in order to confirm, for example, a genetic disease. And you might ask for a very simple investigations, which is called an electromyogram. It is a graph that is drawn when you electrically stimulate a muscle and obtain a certain graph that tells you a lot about the responsiveness of the muscle and the strength of the muscle fibers. I hope this video was useful, and I hope you watch it carefully and you take notes and apply all this on the medical condition that you're gonna select for your semester one project. And I wish you good luck with your project. Thank you. Bye.